Good evening, all, and welcome. It's a Monday evening, and we are back with yet another interesting presentation and some more IVF cases. And of course, we are also here to answer some of your questions. So glad to be here back with Dr. Halyna Strelko. You can see her right here. Hello, Dr. Strelko. How are you feeling tonight? Wonderful to have you back. This is our third or fourth. I'm sorry, I don't remember exactly now, but I'm glad that you are back with us and will present more cases. How are you feeling tonight?
Thank you very much. I feel well. A little bit not good weather today in Kyiv, so it is always not good mood. But now all is fine. I am really happy to be with you, and I am happy that people come in. And thank you to all participants, to all people who take his time to listen in this webinar.
Thank
Uh,
you so much indeed. It's definitely this time of year, November. It's always the weather is not so great, but I'm glad that we are able to be here. And so we should stay positive. That's what we can do right now, right?
yeah, exactly.
Um, yes, and of course, as you know, we will start with Dr. Strako's presentation. She prepared two cases, and she will talk about getting pregnant after plus 38 advanced maternal age. And of course, as always, there will be time for your questions. So go ahead. If you have them prepared, you can type those in right now. But if not, you can always do it afterwards. Remember, this is going to be recorded. And I just also want to mention that, as you know, since this September, sorry, we have started success stories. This is a project that we are definitely very proud of, simply because we see how many different cases can, and how many different cases, and of course how many success stories we've seen so far. So it's amazing for me because there are so many different strategies, different approaches, and the main focus here is definitely to make it happen. And of course, tonight we will hear some more of those. And I'm glad that you are here. Don't hesitate to ask your questions. And I believe this is time to start our presentation. Let me just also mention that if you haven't participated in the previous webinars with Dr. Strelko, let me just introduce her. So she is the IVF expert. She's located in Kyiv, as she's mentioned, and she's the also co-founder of IVMED, located in Kyiv, as I've mentioned. Right. So that is it from me. Thank you so much, and let's get going with our presentation tonight. Okay.
Yeah, thank you so
Thank you
much
so
for your
much indeed.
kind presentation, and we will start. So today we will talking about late reproductive age, and I will show you two cases, more or less similar profile of patient, but little bit different approach. And probably I will try to explain one of this approach is not very good, and why another one is more successful. So, first case, my patient's name Irina, 46 years old. She became my patient in 2021. And the main clinical diagnosis is advanced reproductive age. We know that after 42, 43 years old, unfortunately, in most of cases, it is quite difficult to receive own eggs, to produce embryo from these eggs. But she has done one IVF attempt in another clinic before to come in our clinic in 2020, so 1 year ago, when she has 45 years old. And in previous clinic, they received quite good number of eggs, 8 eggs in total. Unfortunately, only one poor quality blastocyst, and genetic test, next generation sequences test, show that this embryo unfortunately is abnormal. Um, so she has morphologically normal egg, morphologically normal quality, normal sperm count and quality, and I proposed to her, due to these previous attempts, egg donation program, but she said that no, only own eggs. She don't want to try with donors' eggs, because on good ovarian reserve and because on last year they receive poor quality but as minimum one blastocyst, so we decide to go to the stimulation. She has absolutely normal hormonal levels. She has quite good IMH level for her age, 1.1 nanogram per milliliter. She was negative for infections, coagulation test, karyotype, other tests were normal. Her husband has also absolutely normal sperm count and morphology, normal DNA fragmentation rate, normal karyotype, so all was apparently good. She was a little bit overweight, body mass index 31.3, but otherwise all was fine. So we decide to do with her natural cycle IVF because on low number of blastocysts, so decide to try with less stimulation, probably waiting to receive better quality eggs. And doing, if we receive as minimum one blastocyst, to do the genetic test of this embryo and cryotransfer in natural cycle. So we receive one egg, mature. She has done fertilization. Me and my patients were very happy. And after 72 hours of developing, embryo arrest, unfortunately. Okay, for one egg, it may happen sometime, even with young reproductive age. So we decide with her to move to another strategy. Probably try the new stimulation, use the high dosage of FSH, adding LH, because we know that in late reproductive age, normally there is a lack of LH receptors and LH activity. LH is necessary for good final egg maturation. We decide to add also growth hormone, to use special sperm selection methods, and also if we receive good quality embryos, to do the genetic test on this embryo and cryotransfer in natural cycle. So I'm sorry, yeah. We stimulate 10 days our patient, and unfortunately, only one follicle growing. I have seen several follicles, but only one follicle give the reaction to this stimulation, and we receive one egg, one more, it was mature egg. We receive good fertilization, and the same story, 72 hours arrest of development, and unfortunately protocol was closed. So what can we do in this case? The day of her egg collection, I detect, I'm sorry, I should move a little bit this slide. So the day of egg collection, I have seen three follicles in right ovary and 2-3 in left ovary. It was like antral follicles, which I expect that they will grow the first stimulation, but we decide to do the second stimulation in the same cycle, like double stimulation. So one day after egg retrieval, we restart the new stimulation with mostly the same medication, the same, add LH, growth hormone, special sperm selection method, etc. And in this case, we receive much better quality oh, I'm sorry, it is not moving well. Why we decide to do like that? There is now a theory of multiple follicle waves. So now we know that follicles growing by groups, by waves. And in some patients, we can have two waves during the cycle, one in the follicular phase, another one in luteal phase. In some patients, we have three waves, and we should follow these waves, and it permit us time to receive much better response if we will choose the right wave. In follicular phase, we can have not very good wave, but after ovulation, sometime we can detect that there is a bigger wave, bigger number of follicles, we can see that and start stimulation in luteal phase. So in this case, we restart our stimulation in luteal phase 2 days after the first egg retrieval, and we receive quite good response in this case. Uh, so that, yeah. If we compare the stimulation in follicular and luteal phase, we can see that in this work, for example, they comparing the egg donor stimulation, the same egg donor and stimulation beginning in the first phase of cycle and in luteal phase of cycle. And the author of this work detect that the results are mostly the same, quality of eggs absolutely the same. So we can use that to follow the best wave and stimulate in the best period of the cycle. And thanks to that, we receive good response in this case in our third cycle. Yeah, it was quite big dose of gonadotrophin 3000 international unity. The duration was 11 days, and we received in total 8 follicles, 7 eggs, 6 was mature, and 1 was GV, but okay, it may happen sometime. Our protocol, you can see here, good number of eggs, good fertilization. From 6 mature eggs, 5 were fertilized. We receive finally, even with this intact, we receive embryos, 6 embryos, and only one morula we detect in 120 hours. This embryo. Other embryos arrest, and this embryo arrest in 6 days of stimulation. So unfortunately, all our interventions to change the protocol, to change the medication, to change the fertilization method, to use the stimulation in second phase of cycle, they improve the response. The third stimulation was the most successful. We receive quite good number of eggs, we receive good fertilization, but unfortunately, we don't receive viable embryo. So this is the main problem of stimulation in late reproductive age, that we can change a lot of things, but we cannot influence the crucial problem which produce the bad embryo quality. Why we have such problem? Because we have two ways to decrease the quality of eggs in late reproductive age. There are different molecular drivers of developmental arrest in the human embryo. In these scientific works, it was shown all these mechanisms which can produce the arrest of development of embryo. And these factors and mechanisms are due to male partner and female partner as well, because as we know, in late reproductive age, in most of case, male partner also has quite late age, yeah, more than 45. So all these factors together give us the result that embryo may arrest. And another mechanism, as we have spoken in previous webinars, this is the genetic mechanism. It means that there are abnormal number and quality of chromosomes in nucleus. When we are comparing the arrest human embryos and developing human embryos, we can see that in developing embryos, the probability of genetic abnormality is less than in arrested embryo. And more interesting that in arrested embryo, we can detect mostly what we call complex abnormality. It means that not only one chromosome is wrong, but different. So all this mechanism does not work. It is not like by chance something wrong, yeah, like in developing embryo. And if it is only one chromosome problem, sometimes this problem may be corrected by itself. But when it is complex abnormality, it means that oocyte and embryo is not able to correct all these disorders. And if we will see the statistic IVF outcome and age, we can see also that with all eggs after 42 years old, the probability of live birth per started cycle is quite low, and 43 and more, it is like less than 2-3%. So unfortunately, we should know that after 40 to 43 years old, the success rate is very, very poor, and only 0.2% of women theoretically have more or less good chance to become pregnant and have live birth after 42, 43 years old with own eggs. So my next clinical case is about another patient. She has more or less the same profile. Her name is Sophie, 46 years old. She became my patient in 2019. And also the main clinical diagnosis was advanced reproductive age. And she has second marriage and one healthy baby in her first marriage. And 2 years ago, she decided to become pregnant, and unfortunately, it is not working. Her IMH level was also not so bad, 0.9. For this age, it is excellent. She was a little bit overweight, body mass index 41 kilogram per square meter. No infertility treatment before. Husband has normal sperm parameters. So, okay, from the beginning, I discussed with her the egg donation program because, as we have seen in most of cases, unfortunately, it is only one realistic option. So, but the main question about egg donation is, how do you select your egg donors? Who are all these people? How they are investigated? Is the girl which I will choose will be nice, will be good? So mostly these kind of questions. And I would like to show that we have really very, very strict selection of egg donors. First of all, we try to contact with them by different methods, and only 20% from all these leads pass the primary interview, because all these leads, then they should call, and our call center speaking with them, and only 20% are accepted for further investigation. Then from these 20%, only 30% come to the clinic by different reasons, because probably they change their mind, or because we decide after listening the interview that it is not good candidate. So only 30%. After the first examination, only 50% pass examination and has quite good result to start the program. So we can say that only 3.3% of all our leads, if we can say like that, became donors. So we have very, very strict selection. And we have very good egg donors results. High blastulation rate, high fertilization, high survival rates of our eggs. We discussed with my patient that, okay, we have chosen nice egg donor from our database. We have quite good choice actually. From 2020 till 2021, we increased twice our database of egg donors. So there is really a good choice, and we decide to choose this girl for egg donation program. We fertilize these eggs and receive good result. 5 excellent blastocysts. You can see that 4AB, 5AA, and also we have done the genetic test, and only one was abnormal. Other embryo were absolutely normal. So we decide to do the cryo transfer, and by standard way has done with replacement hormonal therapy protocol. Standard protocol: 8 mg of estradiol, 800 mg of progesterone. Unfortunately, endometrium always was not so good, 6-7 millimeters, and 2 consecutive attempts HCG was negative. And okay, embryo are normal, all is fine. So what to do? We decide with her to do the natural cycle protocol, cryo protocol. It means that we following the growth of her follicle, looking when this follicle will be ready to ovulate, controlling the hormonal levels, and when we can see the ovulation, we count in 120 hours and doing the transfer. Why? Because during the natural cycle, there are different types of estrogens circulating in the blood, and sometimes it may give much better result on endometrium quality and thickness. And that's true that we have very good endometrium in this third protocol. And in this case, we received the positive HCG result, and it was really good moment when we has done the first ultrasound and have seen that she has pregnancy. Patient was very, very happy. And like take home message at the end of my presentation, I would like to say that the probability to achieve a viable and genetically normal blastocyst, unfortunately, is very, very low after 42-43 years old. And the best treatment option for advanced reproductive age is still egg donation, even in case of good ovarian reserve and apparently good egg quality in healthy women, but unfortunately the quality of eggs in most of cases is not so good. In some cases, it is important to follow the natural cycle protocol for the transfer of frozen embryos. And in our clinic, most of cycle of cryotransfer are done with the natural cycle because the hormonal level is different. For example, we are measuring always the progesterone level before the transfer, and in natural cycle it is twice higher than in artificial cycle. So in all cases where it is possible, we try to do the transfer in natural cycle, even for egg donation program, and it is really working better in some cases. Thank you for your kind attention. I will be happy to answer all your questions. I see that there are some questions.
Yes, there are, of
May
course.
I
Thank you so much, Dr. Halyna, for presenting those two cases. Definitely, again, as always, interesting ones. And I think that many patients will find this useful, as always, as well. And now it is time for your questions. So don't be shy. If you have anything you can share right now, you can type the questions in, because Dr. Strelko is right here for you to help you out with any of your questions, of course. And they are coming. I see that. So don't worry, Dr. Halyna. I'm sure there will be more questions here. And let's have a look. The first question is in from Lily. How can AMH levels vary? Is it good to check it a couple of times during a month or not necessary?
Thank you very much. Excellent question. Recently, I have seen the article about IMH level variability. It is a very interesting question because first, IMH level, it is thinking that it is stable, but finally it may change during the cycle 20-30% in different phase of cycle. It is increased when LH is higher and decreased when LH is lower. Second point, that from cycle to cycle also may be variability 20-30%. And also important things about IMH level, that the level that patient has in blood circulation and level that you receive in your analysis, it may be different and influenced by machine which produce this analysis, reagents which doing with the help of which are done this analysis. Also pre-analytical etap, it means that if your blood before to put in this machine was frozen or heating or not put into 3 hours and waiting, storing for a couple of days or something else, it may affect even twice the result. So, of course, you can check IMH level even 3 times per cycle. But as for me, better option to do the same day ultrasound, doing antral follicular count. It means count how many antral follicles do you have in your ovary in this moment, take blood for IMH and see the both. If both results are more or less saying about the same, I think it's enough to understand your real ovarian reserve. If, for example, you have bigger antral follicular count and less IMH level, probably necessary to take in consideration rise the antral follicular count. Also, there is a very interesting work about that they comparing people with how to say high IMH and low antral follicular count and opposite, and show that if there is this discordance, better to take in consideration the visual number of antral follicles. So probably that's all.
Thank you so much. Of course, definitely interesting. Thank you for explaining, Lily. Thanks a lot indeed. And let's have a look. Okay, there are more questions coming up right here. There are 3 parts from the very same patient. Let's have a look. I'm 43. My AMH is 1.01, and Sorry, I did 10 IVF rounds until now. Only one was successful. What is your suggestion for my age for next IVF? I tried egg donation last month, but it wasn't successful as well. Anything you can advise?
Uh, Thank you for your question. Yeah, it's a difficult situation because 10 IVF attempts. Okay, to understand better the situation, necessary to see how many eggs were produced during all these attempts, the percentage of fertilization, the percentage of blastulation, if you has done the genetic test of embryos, if you have done, for example, the specific test of endometrium receptivity. Because, for example, if all these attempts or most of these attempts you has excellent embryo with normal genetic and, for example, does not test your endometrium, probably will be better to go to the testing of endometrium receptivity. About egg donation, also necessary to see how many eggs were used, how many blastocysts, the quality of this blastocyst, protocol of preparation. So like that is difficult to say something exact. Probably in this situation, I try the egg donation. I try to see the endometrium receptivity and try to prepare your endometrium in natural cycle. But necessary to have more details to understand the situation.
That's understandable, of course. Thank you so much for sharing and for your question. Remember, there's a way for you to get in touch with Dr. Halyna and her team at IVMED, and I'm sure they will be able to help you with some more details. After we finish, you will be redirected to the site, to the profile of Dr. Halyna on our site, and there is an option to contact as well. So you can use that, or just simply get in touch directly with Dr. Halyna, the whole team at IVMED, of course. All right, and there's a thank you from the patient for you right here as well. Okay, now we have a question from Roman. Okay, thank you for that question as well. You have experience using growth hormone to increase male fertility?
Thank you for your question. Unfortunately, me personally, no. I don't work in with a male partner. Mostly our urologist working with them, but he does not using growth hormone. We are using sometime the stimulation with FSH and HCG. Mostly in case of azoospermia, and sometimes we receive a couple of sperm cells after this stimulation. But growth hormone, unfortunately, no. I have no this experience with male partners.
All right. Thank you for the clarification. Thank you for the question. And of course, there's a thank you from the patient right here as well. Okay, let's have a look. Another question. What is the best number of days with progesterone before frozen embryo transfer?
Good question. Thank you very much. There are also different publications about that. Some of them say that, okay, it is maybe 5, maybe 6. Like if we start progesterone Monday, we should do the transfer Sunday. Oh, sorry, Saturday. But another publication say that, okay, better to follow 120 hours. And a recent publication of Humaidan say that, for example, if you are using natural cycle IVF, 2 hours after HCG triggering your progesterone rising. It means that if you would like to do, you have natural cycle, for example, and you would like to do your transfer Saturday, your trigger should be done late evening Sunday, previous Sunday. So like not one day before, like for ovulation, like for triggering for IVF, but little bit later because progesterone rise more quickly and earlier. For egg retrieval, we are doing 36 years before. 36 hours before egg retrieval, but for cryo embryo transfer, we are doing less. We're doing just a couple of hours before you start your progesterone. That's why should be 120 hours of progesterone in normal case. But if you has done the endometrium receptivity with ERA test, sometime necessary to do 140 hours or less, like 72 hours. So, but it is depend on the result of your test.
Wonderful. Again, thank you so much for the question, and thank you for helping out. More questions are coming in. Let's see, another interesting one. I know there is a condition when FSH receptors are irresponsive to FSH. Where can I test this condition? Can it be treated in some way?
Very good question. Thank you very much. Yeah, it's true that it is described like FSH receptor mutation, and they are not receptive to standard FSH therapy. So sometimes we can use for stimulation HCG, sometimes we can use LH for stimulation, and unfortunately it is impossible to treat because it is congenital condition. But we can try to use, if for example own ovary working and sometime you have own ovulation, it means that your body detect your own FSH. It means that for stimulation you can use protocols like anti-estrogens, which will produce the rise of your own FSH, and after adding something like low dose HCG or LH. Sometimes it is possible that it may be helpful. About testing, some genetic laboratories specialize to this test, and they can detect the mutation of FSH or LH receptors. Our laboratory unfortunately does not do this test, but I know a couple of laboratory where you can do that for sure.
Thank you. Definitely interesting one. Thanks a lot indeed. And as always, there's a thank you for this question, but also the previous one. Thank you for a great answer, as you can see. Okay, next question. Let me just have a look. Lily has another one. Is there any way to limit risk factors such as high blood pressure when receiving a transfer at advanced maternal age?
Yeah, this is also very good question, and it is true that in advanced maternal age, the main risk it is obstetric complications, high blood pressure, diabetes, thrombosis, placenta previa, etc., etc. About prevention. If a woman has she's overweight, will be good option to decrease the weight. Second point, to see insulin resistance before the treatment, because insulin resistance provoke the concentration of adipocyte in belly, and these provoke increase the probability of insulin resistance and high blood pressure. So it is like circle. And during the pregnancy, progesterone increase insulin resistance. So if in late reproductive age woman has abnormal weight, will be good option to try to decrease it, at it will be the best prophylaxis of high blood pressure. Also, less medication woman will receive, better it will be for her health finally, yeah, in this case. So try to do in natural cycle. And also there is a scientific works which say that natural corpus luteum produce some specific substances and growth factors which improve the probability to go with the pregnancy till term, and artificial cycle sometime may increase the probability of high blood pressure. So probably like that. and all methods which improve the placental blood circulation also will decrease the probability of high blood pressure.
All right. Thank you, Lily. Again, an interesting question. And let's have a look. Astrid has a question. Do you offer the option of non-anonymous egg donors?
Thank you for your question. In Ukraine, we have not very strict legislation. So as clinic, we have no right to give information, personal information about our egg donor, but we have agency who are not clinic, and they can provide this information and give you more, how to say, full profile of egg donor.
Understood. Thank you for clarification then. And let's have a look. Does taking dose of estradiol and estriform create fibroids?
Good question. Thank you very much. Finally, fibroid is estrogen dependent and progesterone also dependent benign tumor. So if you will take during long time and big dosage, probably per se it will not provoke, but if you have little fibroid, it will help to this fibroid to increase the size. But you know that the preparation protocol lasts normally 2 weeks, 3 weeks, but pregnancy lasts 9 months. It means, and during the pregnancy, fibroids growing much faster than during the preparation, whatever dosage you are using. So also the main problem is not if you have fibroid, not the preparation, but pregnancy, which will produce the growing of this fibroid.
Okay, thank you. And now might be our final question. So, of course, as always, if you have more, you know what to do. I'm sure there will be more, but I just want to encourage everyone. So we have more questions for Dr. Strelko. And here's another one. Some IVF centers suggest to do BCL6 test with Cooper Surgical. Do you think it is important?
Yeah, we can thinking about that. In our clinic, we don't use this method, so I have no personal experience. But okay, necessary to talking with your doctor. You know, with fibroid, there are different options, different approaches. Some doctors propose to do surgical intervention. Some doctors propose to use medication to shrink a little bit fibroid before the further preparation. There is very interesting method named HIFU method when some specific ultrasound, Doppler ultrasound, is increase the temperature inside this fibroid and after this fibroid shrinking. So different approach exists and necessary to see the exact situation, the place where situated your fibroid, the blood circulation, the is this fibroid close to endometrium, and if there is a big risk to harm endometrium during the treatment. So a lot of things which should be taken in consideration.
Of course. Again, thanks so much for yet another interesting question. And well, there is one more question that is a bit of a longer question. Before that, there are thank yous from previous patients, as you can see. And Susan has added one more. I'm 39 from Scotland. Embryos are not genetically tested as standard in my clinic. During my first cycle of IVF in August, I had 13 follicles, 6 eggs, 4 fertilized, 1 day 5 blastocysts, 3 BB transferred but failed, and 2 4AA blastocysts were frozen on day 6. I have had 2 frozen embryo transfers, but these both failed as well. Are day 6 embryos less likely to implant due to slow growing? Based on the above, would you advise I try again with my own eggs or look for a donor?
Good question. Thank you very much. As for me, there are a couple of things which will be good to clarify. For example, 13 follicles and only 6 eggs. Okay, why? Because follicles were not appropriate size, or because the trigger was done earlier, or because you have some problem of egg maturation. And for example, when eggs are not mature enough, we receive less eggs. Yeah. So probably for the stimulation will be good option in second stimulation to postpone one today, to give probably bigger dosage, to give probably double triggering, and increase the egg maturation. Because when we receive, there is a nuclear maturation which can be detected with microscope, and there is a cytoplasmic egg maturation which cannot be unfortunately detected like that. But these produce less fertilization. If your cytoplasm is not mature enough, you will have not very good fertilization, you will have slow embryo development, and probably no very good blastocyst quality. So as for me, if it is only your first IVF attempt, I prefer to try another stimulation. Necessary, of course, to see your first protocol, but will be good to modify, to probably increase the dosage, increase the duration, doing something like double triggering, and try to receive more eggs to see if you will have better blastocyst formation rate. Probably to use calcium ionophore after fertilization to improve fertilization and embryo development. And about day 6 embryo, the probability of implantation, it's true, little bit less likely, because they has little bit more percentage of genetically abnormality. But also it is not the rule, because depends on cultural medium. In some mediums embryo growing much faster, in some medium blastocysts arrive rise in 6 days. So this question necessary to see with your embryologist. And also, if for example your egg collection is at 2 p.m. for example, it means that fertilization will be at 4 or 5 p.m. It means that your 6th day finally not 6th day, but like end of 5th day. So this is necessary to see with laboratory. The more often in this laboratory with this medium blastocyst formation on 120 hours or 140 hours. So all these things necessary to discussing with them to understand better what happened. But as for me, I try second stimulation in your case.
Thank you for another advice. I hope, Susanna, that was, of course, helpful for you. Thank you so much for sharing. And there's another question from Natalia. 41, one blastocyst on average after each stimulation, PGTA or not? Some say not. Let the nature decide. What is your opinion?
Very good question. I have mostly every day such questions from my patients. Look, PGTA, this is a method which does not improve blastocyst, okay? It is the method which permits to select something and to transfer in first attempt best embryo, second attempt little bit worse, etc., etc. So in case you have only one blastocyst, as for me, you should be very careful, because PGTA may give some false positive and false negative errors as any method of testing. Whatever method you can use, you will receive some percentage of mistakes. Second point, that the cells which were taken from embryo may be not representative about all embryo. It means that the cells which are taken from embryo from trophectoderm, so future placenta, has normally higher percentage of genetic abnormality than cells staying inside of embryo. So if you receive mosaicism or even abnormal result, sometime in some percentage of cases it may not represent the real situation, and you will how to say, excard this embryo from further using, but this embryo may have chance to implant and give healthy baby. So as for me, if you have only one embryo and has no very serious reason to do PGD, I prefer to not doing, because it may decrease your chance to receive pregnancy. But okay, necessary to see. For example, if you have previously 5 attempts and in each attempt you has like trisomic baby, of course necessary to do the testing. So necessary to see the exact reason why to do the testing. But in such cases, in most of cases, as for me, better not to do the PGTA. Also, when you are doing biopsy, sometime if embryo is not 5AA, it may be harmful for this embryo. There are different methods of biopsy, different influence, but finally it may decrease the viability of this embryo. So as for me, I will counsel to you to not do PGTA in such cases.
Thank you for that recommendation as well. And again, as you always know, Natalia, thank you for your question. We will be slowly finishing, okay? So this is the final call for the questions. Go ahead, type those in. And of course, there is a thank you from previous patient in regards to your answer. And one more. I am 43. This is from our previous patient as well. What is your recommendation for my next IVF? Use donor eggs or my own eggs? My husband has problem with quality and quantity with sperm, but we have one son and one IVF. I was pregnant with 4 babies, but lost all of them at 26 weeks.
Oh, really, really not a good story. Yeah. Okay. Yeah, it's true that at 43 years old, the probability of pregnancy with own eggs is not so good. It's true. And second point that, and this is the continue of this question, yeah. And also about husband's sperm parameters. If, for example, very, very bad sperm parameters, but excellent eggs has possibility to restore some problems and some DNA breaks in sperm from sperm side. But if we have problem inside of sperm and inside of cell, as I have shown in my slide, it is increase the probability of embryo arrest and add additional problem to development of embryo. So as for me, at 43 years old, probably better to try with egg donation. Or if you have tried only once, for example, okay, possible to try with another stimulation, try to receive more eggs, and probably one more try with own eggs. But the probability of success is not so high, and necessary to understand that whatever intervention we will do, we can only increase the quantity of eggs, but in most of cases we cannot influence the quality.
Understood, of course, as well. And thank you from the patient for you right here. And as I mentioned, it looks like that was our final question. So thank you everyone for joining, for your Definitely interesting questions, and I do hope that it has been useful. Well, actually, no doubt, Dr. Strelko. How hope you are having also a good session, right? It is a good session after all. So thank you so much for spending another evening with us. And I just want to mention before we finish that Dr. Strelko will be back with us on the 1st of December. So next week she'll be back and she will have more cases. So join us, sign up already, and I hope to see you here as well. And Dr. Halyna, anything else you would like to add before we finish?
Thank you very much for your time, for your attention, and for your excellent questions. It is really interesting, and I was really enjoyed to be with you this hour. Thank you very much.
Thank you so much. And as you can see, amazing comments are right here. Thank you for your great webinar, amazing discussion, and of course the glasses thing. Thank you so
Thank
much. And as you can see, another one. Thank you for the interesting webinar. Definitely interesting. So thank you so much. And I'm looking forward to our next webinar on the 1st of December, as I've mentioned. So go ahead to my IVF Answers, where you will be able to sign up for more events. There are still few events left. As you know, we will be finishing in December, but there are some more cases to discuss. So don't hesitate. And of course, this has been recorded. You will be able to find this tomorrow on our site, myivfanswers.com.
you.
Thank you so much. See you soon, very soon. And as you know, we will be coming back also tomorrow, 7 p.m. UK time. Another topic, genetics, PGTA, PGS. Just go ahead and sign up. And I hope to see you here tomorrow and, of course, on the 1st of December. Okay? Thank you so much. Take care. Good
Bye.
night.